Good afternoon, and thank you for joining. I'm Sherilyn Francis with the Georgia Health Information Technology Extension Center. We invite you to connect with us at www.ga-hitec.org and via social media at Georgia HITEC using hashtag Health IT Solutions. Georgia HITEC is the only federal and state-endorsed expert to assist providers in the achievement of meaningful use of EHR technology. We are located at the Morehouse School of Medicine, National Center for Primary Care. I present to you today's webinar entitled, A Deeper Dive into MIPS Quality and Improvement Activities, presented by Ms. Phoebe Nelms and Ms. Liz Hansen. In compliance with ACCME guidelines, the following presenters have no financial or other relationships with the manufacturers of any commercial service discussed in this educational activity. The objectives for today's webinar are to identify and review methods to select quality measures that are best for your practice, to recognize the tools needed to determine your MIPS quality score, to understand effective documentation of your improvement activities, and to analyze the impact of improvement activities implementation strategies. And now, Ms. Nelms.
Okay, so what is MACRA? And why was this bipartisan legislation passed? MACRA stands for the Medicare Access and CHIP Reauthorization Act, and its intent is really to create a new framework for reimbursing providers. It consolidates existing quality reporting programs, and it is designed to be budget neutral. Since Medicare is the main driver of future federal spending increases, and if you look at the numbers that are projected, they are staggering, we can see why payment reform is necessary. And Medicare is a large enough vehicle to use to drive this transformation of healthcare. The transformation is away from the fee-for-service model and toward the quality and value-based reimbursement model. So, how is MACRA implemented? It creates the Medicare payment reform through the Quality Payment Program, or the QPP. So MACRA is the legislation. It supports care delivery and promotes innovation, and the Quality Payment Program under that legislation is part of a broader push towards value and quality. So the vehicle for measuring and reporting are the two tracks of the QPP program, either the MIPS track or the APM track. And so there are 4 performance categories, or the 4 MIPS components. Quality making up 60% of your score, and this replaces former PQRS reporting. The new category of improvement activities makes up 15% of your score, and the advancing care information category makes up 25% of the score, and this replaces meaningful use EHR incentive reporting. And cost will not be considered this year, but will in future years, and it replaces the value-based modifier. So we thought we would just give you a quick overview of the entire program, but we'd also like your interaction and to know your answer to the following question. How are you planning to participate in the Quality Payment Program for 2017? Are you going to report for a full year, partial year, just do the test, you're not sure yet, you're not going to do it, or this doesn't apply to you? Okay, so this is great. A lot of people are planning to participate for the full year, and some are still unsure. So the purpose of this webinar is to help equip you to know, well, if you're unsure, how do I actually do this? And that might help you make a decision to go ahead and participate. Okay, so moving on. This year, we'll talk about the options for this year. Pick your pace. So option 1 is you're not participating in the Quality Payment Program at all. You don't send in any data in 2017. If this is your choice, then you will receive a negative 4% payment adjustment. Option 2 is to do the test. So if you submit just the minimum amount of 2017 data to Medicare, for example, one quality measure or one improvement activity for any point in 2017, then you will avoid that downward or that negative payment adjustment. Option 3 is you submit data for part of the year. If you submit 90 days of 2017 data to Medicare, then you may earn a neutral or a positive payment adjustment, and you may even earn the maximum adjustment. And option 4 is to participate for the full year and submit that data to Medicare, and then you may earn a positive payment adjustment. So it's good that you have choices. They have designed this flexibility in the first year because it's new and because they want everyone to be successful. So we have another question for you coming up, and that is about your past participation in a quality program. Did you participate in PQRS in 2016? So this will help you to decide how much effort might be needed to participate in the quality program going forward, and you'll have some data to start with. Okay, so almost half have participated in PQRS in 2016, so that's great, a great place to start. So now that we've come to this portion of our presentation, I am going to turn it over to Liz Hansen, and I have dubbed her the Maven of MIPS because she has really put together some very practical and useful information that will help this really break it down to doable pieces of action items. And so Liz, you have our attention.
Thank you, Phoebe, and welcome everyone. So the first deep dive we're going to take is into the quality component of MIPS. And one of the reasons we wanted to do that initial overview that Phoebe did is we wanted to make sure that everybody understood when we referred to MACRA or MIPS or QPP, we're basically talking about the same thing, especially on this particular webinar. So for the quality component, there are 271 measures available. Now, I do have to say that last week, when we looked on the QPP site, which we'll discuss in just a few minutes, there were 284. So apparently the number of measures available to you are being reduced, and we do expect those to go up. But I don't think that will impact most of you. If it does, then perhaps we need a side discussion. The quality component is so very important because it accounts for 60% of your total MIPS score. And I will say that this component seems to be the most confusing for folks, and we are going to take a deep dive into it. And you know, when you take a deeper dive, you might get wet for a little bit longer. So hopefully everyone will appreciate what we go over today, and then reach out to us if you need some more specific or personalized assistance on this particular component, because it does get a little confusing, and hopefully we can get rid of some of that confusion today, but we want to make sure that you know that you can do this. So for the quality component, you have to report 6 measures, and you want to report the 6 measures that best fit your practice. We do recommend that you actually select 8 to 9 measures because we want you to have a little bit of flexibility. I was just speaking with someone this morning who had picked out their 6 measures, but they were reporting on 9 measures, and when we checked their reports today, found that one of their measures had increased by several points that would impact their total score. So if you pick out 9 to 10, 8 to 9 measures, it gives you some flexibility. And we'll show you in just a few minutes how that works. You do need to include 1 outcome measure, and if no outcome measure is available or works for your practice, then you can select a high priority measure in its place. And in just a few minutes, we'll see how you can tell whether a measure is an outcome measure or a high priority measure. I do want to point out that if you're participating in an ACO, most ACOs will require specific measures to be reported. They will likely be doing your reporting for you, and if you participate in an ACO, we would want you to reach out to that ACO and confirm what the requirements are, get the guidance from them, make sure they tell you or you're following what their guidelines are, and that they are going to watch your numbers. In the ACO environment, what they're doing is they're aggregating everyone's data, and we typically see very high scores, oftentimes higher scores than you might get as your individual practice if you did it. So, but we do want you to reach out to your ACO and make sure that they are reporting those measures for you and that you're doing what you need to provide them with that data and to have the best scores that you can. And we'll talk about scores in just a little while. Groups that are in APMs are qualify for special scoring standards under MIPS, such as the Shared Savings Program Track 1 or the Oncology Care Model. So you would typically report your quality measures through your APM. You do not need to do any additional measures for MIPS, a quality category, and we do want you to refer to your APM for direction and guidance on what you need to be doing, if anything. For the rest of you, then let's take that deeper dive. So how do you know what best fits for your practice? And what we'd like to think is that the best fit for your practice would be those measures that align with your specialty. And you can actually filter for your specialty when you look at these measures on the QPP website. And we'll take a look at that in just a minute. I do have to tell you that what we have found is that many specialty measures are not available on your EHR. And so you may look at the filter for your specialty measures, and you may see 5 or 6 measures that are associated with your specialty, and then go to your EHR to look at the measure tracking and find that half of those measures aren't on your report and can't be covered through your EHR. So we are going to talk about the measures that your EHR supports are the ones that you want to use if you're reporting through your EHR when you attest, or if you're reporting through a registry. If your system can't track the measures and you're not using claims, which gives you even less flexibility, then you're not going to be able to use those measures. So yes, we'd love for you to be able to use your specialty measures. We have found that A, many of those measures don't really apply to your specialty, and B, oftentimes your EHR system doesn't track for those measures. So I would ask you to be a little patient with this. We do anticipate these measure sets will be built out in the future, but for this year, we may have to do a little strategizing and determine what best really means this year. Now, we do recommend that you use the measures with the best scores. Now, again, best may seem nebulous to you, but and the highest score, such as a 92%, isn't always the best score because there's inverse measures. And there is a way to see what measures are inverse measures and what your scores are based on the percentages that are provided in your report. But typically we think that the best scores are those that have the highest percentage on your report. Now, when CMS put this program together, what they anticipated was that your focus would be, best would be what aligns with your specialty. But because there's not much flexibility and not that many measures for several specialties, then we typically will recommend that you utilize the measures that your system can report that have the highest percentages. Of course, we do want you to use measures that align with practice initiatives. For instance, if you're doing an initiative with your patients on anticoagulants, then you might use the quality measure that goes with that initiative. And you can find that out by determining what initiatives you have going on in the practice, then looking through those 271 measures and seeing if any of those go with your initiatives. Then there may be initiatives that you'd like to see improvement on. So perhaps you have a mediocre score, for instance, on A1C, and so you want to do some outreach, maybe do a gap report, do some proactive work on bringing in those diabetic patients and testing the A1C. And so you may be doing, sorry about that, you may be doing some other type of activity, or you may want to do some other type of activity that would improve a particular quality measure. And we do encourage you to do that. That would be great. And if all we had to worry about was doing what worked best for your practice, that would be the methodology we would take. However, we are a little concerned about scores. The score does impact your MIPS total score, and so that does impact your potential to get a positive adjustment. So we have to take in all these factors when we're considering, and the best way to do that is to look at what you've got available and to look and see what those percentages are to see how they impact the score, which we'll look at. For full credit, we do want you to remember that you must have for each score, unless you're doing the test option, if you're using the 90-day or full year option, you do need to have a denominator of at least 20, and 50% of those should be Medicare Part B patients. On most of your systems, if you're using your EHR to obtain your quality measure data, then you should have much more than this, because it's going to do all of your patients. It's not going to look just at your Medicare patients. And so we would say, if you're using your EHR and not using claims-based, that you just want to make sure you use a measure that has at least 20 in the denominator. I have had several people be very excited about incredibly high scores on some of their quality measures just to realize that they only had 18 in the denominator. So we don't want you to have that surprise when it comes to be December. So how do you know what measure options there are, what's available to you? So the first thing we recommend is that you get your EHR quality report, or look at perhaps some past performance reports like that that's associated with your PQRS, perhaps that report that you used last year, to see what measures are available to you and what your scores are. We do point out that not all measures are available for all three methods of submission, which are EHR, registry, claims-based, and then there is a self-attestation that you could do that's not available to you yet. But we do want you to go to the QPP website, and we have the link here, where you can look at all of the measures and see which ones, the descriptions for those measures, that match up with those that are showing up on your quality report. We're actually going to take a look at some of those quality reports. Now, when you go to that QPP site, you will see, if you'll scroll down just a little bit on the screen, then you will see your ability to search by keyword. So if you wanted to see if there was a quality measure for an anticoagulant initiative that you were doing in your practice, then you could put that in the search, and 90% of the time it'll find what you're looking for. Sometimes you have to hold your mouth just right. One of the other things that you can do is you can filter by high priority measures. If you're just looking for a high priority measure, or you want to confirm that you've got one, you can filter by your data submission method. Again, not all measures are available to submit through claims. That's a much smaller set of measures available if you have to submit through claims. And it will also tell you if you can submit particular measure through your EHR submission or through a data registry. You can also filter for a specialty measure set. Again, I would just ask you to be patient with this one. Many folks have used this and found that the specialty measure sets didn't really work for their practice, or that the measures weren't available on your EHR. So if that is true, then we would go back to, let's use the measures that you have the best scores for, that work within your practice workflow, that you can improve on, and then perhaps next year there'll be a greater variety of measures for you to use. Now, when you do come to this site, you can actually pick these measures and generate a report so that you can, if you'd like, have a soft copy or print out a report of some of your options. Again, we recommend you pick 8 or 9 at least, and then focus on the 6 that seem to be best for your practice. Now, when you click on a specific measure on that from that site, then you get a description of the measure. This one, for example, is controlling high blood pressure. If you look at the arrow on the upper left side, you see that you get the measure number. Now, quite frankly, this should say measure numbers, because for some reason, which I cannot explain nor defend, we have multiple numbers for measures. You have the CMS number. You may have an E-measure NQF number. You may have an NQF number, and you may have a quality ID number. The reason I point this out to you is because different EHRs use different numbering systems. Some of you may have an EHR that gives you the CMS number. Some of you may have EHRs that give you the NQF number. So rather than you being frustrated and not being able to find the measure or having to look through descriptions to find the measure, this gives you all of the numbers that would go with this measure. Most of your systems have the CMS number. Some of them still have the NQF number. The reason that I will point out the quality ID number is when we go to compare scores and to do a crosswalk on what your score is going to be from your percentage, that document, believe it or not, uses the quality ID number. So as we all know, this isn't quite a perfect world, and hopefully at some time in the future, these will all become one number. Now on the right side, you will see measure type, and this tells you whether this is an outcome-based measure. And as we mentioned previously, you want to have either an outcome-based measure, and if you can't find one that works that's outcome-based, then you need to have a high-priority measure. And as you can see, this measure is both. I also want to point out in the middle of the screen, you will see the data submission method. This tells you that this particular measure for controlling high blood pressure can be submitted via claims, through your EHR, through the CMS web interface, which is not available yet, or through a data registry. Now, there is a document that provides you with a large list of data registries that have been approved by CMS. There are costs associated with these data registries. The registries that list is available on the QPP resource site. I do ask that you carefully look at that because not all registries have all measures available. So that would be another step that you would have to take to make sure that the measures you picked out are available through a certain registry submission. The registries do have a cost associated with them, and just recently I was speaking with someone who found that the cost of using a registry, they were trying to avoid having to do a specific upgrade on their system that was going to cost about $2,500 to do submissions through their EHR. What we found was the typical registry price per provider, when added up, was more than what they would have had to pay. So do a little return on investment analysis. Take a look at what the costs are compared to when you compare your EHR upgrade cost for submission and the registry cost. And of course, on the right, we have the specialty measure set. We have had a limited success with those being useful. That was about as diplomatic as I could be. All right. How do you know what the best scores are? How do you know what your scores even are? So what you want to do is you want to review your MIPS quality report in your EHR. And now that I've said that, I'm going to say most of you don't have a MIPS quality report yet in your EHR. We anticipate that over the next 6 months, your systems will be upgraded to have a MIPS quality report, and some of you already have that, and we're right tickled with that. But many of you are going to have to go to your Meaningful Use Clinical Quality Measure report or dashboard to see what your current percentage for the measures you selected is. So we're going to look at that with you. You could also review your QRDA report. I have to say that report has got a lot more data than you really need to look at initially. It is a little more confusing and somewhat intimidating. So if, for right now and for this year, if you could use your MIPS quality report if you have it, probably your Meaningful Use Clinical Quality Measure report or dashboard, then we can pick out and estimate what your scores would be from those reports. Then you would cross-reference your scores with the Decile Report, and I'm going to show you that in just a few slides. Now, remember that your measure scores will differ based on your reporting method. So a measure is going to probably yield a higher score if you report through your EHR. Your second highest scoring opportunity, well, that's weird. I'm sorry, I seem to have lost my, oh, thank you very much. Your second highest scoring method will come through using a registry or reporting through a registry. Your lowest scores will be if you submit through claims-based, and that has the greatest limitation on the quality measures available to you. So if the cost is not too high, and if your system provides it, then it does appear that reporting your measures through your EHR is going to give you the highest yield. But many systems cannot report through the EHR, and in that case we would recommend, if you can afford it, to go through a registry. Now, I know this is a little small, but I do hope that you can at least get an idea of what we're talking about here. This is a Meaningful Use Clinical Quality Measure report, and we have drawn arrows at what we feel are the highest 6 measures. So we would take those 6 measures, and we would look at the percentages for those measures, and we would crosswalk those to see what our anticipated score would be, or to get an estimate of what the MIPS score would be based on these percentages. Going to make this a little more clear to you. Hang with me. This is another example of a Meaningful Use Quality Measure report. This particular system now has a MIPS report for quality measures and now incorporates the deciles in the report, and you don't have to do the crosswalk, which is pretty convenient but not free. But this is another look, and you can see I don't like that this last column says score, because I try to think of score as the points we'll get for MIPS. So I tend to talk about this as the percentage that you've reached, and the score I try to apply to the points you'll get for MIPS. This last example is actually an example that is a MIPS report for quality measures. You will see, however, that next to the last column that says decile says NA. This particular system has not uploaded the deciles report into the system, but when it does, then it would automatically calculate the points. Again, we'll look at column 3 to see what the performance rate is. We'll pick out our best 6, work on our best 8, but pick out our best 6 to see how those scores look. Now, to look at what your estimated scores would be, we do use the decile report. If you go to the QPP resource library and scroll down to the quality measure specifications document, and then download that document, then you have the decile report where you can get an estimate of what your percentages will yield as points for MIPS. Let's take that a step further. And here is that lovely report. Now, folks, I have to say, when you first look at this report, it is intimidating. But what I'd like to point out to you on this report is it gives you a description of the measure. It gives you the measure ID. I would like to reflect back on that previous screen when I pointed out the measure ID, which is different than the CMS number, different than the NQF number, which is what's showing up on your EHR probably. So oftentimes the first time you have to search for these particular measures to see what the measure ID is. And right now there's nothing we can do about that. But if you, for instance, need to find documentation of current medications, then you can do, if this is a spreadsheet, you can do a find for that measure or for anticoagulant, and it will take you to where that measure is. It may take you to a couple, may have to search a little bit, but you will find it on this document. The next thing in column C, you see the submission method. So for this first measure of the A1C poor control, you'll see that you have a claims option, an EHR option, and a registry option. That is not true for all measures. For instance, if you'll look at line 8, the colorectal cancer pathology measure, then you have that available in claims and through registry, but not through your EHR. So it's important that you make sure that the measures that are showing up on your EHR report are measures that you can submit for through your EHR report, which is typically true. But it doesn't mean that you could submit it through claims-based if you want to. So we just recommend that you check the 8 measures you picked and make sure that you can submit them the way you'd like to. You will also notice that this gives us a measure outcome, a measure type, so we can see if it's an outcome-based measure. And again, one of your requirements says outcome-based if possible, if not, then high priority. Then you have your deciles, and the deciles tell you the points you're going to get. If it's decile 3, you get 3 points. If it falls in decile 4, you get 4 points. Decile 5, you get 5 points. You will notice that the way that you submit will change may change what decile you fall into. And again, we told you, EHR, you're typically going to get higher points. So let's take this a step further. From that previous report, we determined that we wanted to go look at CMS 147 NQF 41. That is the measure that we want to look up first. Now we go back to the QPP site and we look up that measure, and you can search on CMS 147 and we see that the quality ID is 110. Now folks, you could just go to the spreadsheet and do a find. But you may find that this is faster if you just look all of them up and write down your quality ID number from the get-go. Then you'll go to your decile report, and you will see that I've got shaded measure 110, which is preventive care and screening for influenza, for the flu. And I've got those highlighted. You'll see that it is available. You can report through claims, the EHR, or through a registry, or through the web-based submission. It is a process measure, so it won't count as an outcome measure for you. And you will remember, or maybe not, that our score, which I said I wasn't going to use that term, that our percentage was 61. 61. So let's go see. If we submit via claims and we have a 61, then we're going to be in column I, decile 6, we would get 6 points for that. If we're going to submit via EHR, and a 61 falls in decile 9 if you submit through an EHR. If you're submitting through a registry or through the web-based tool, then that score of 61 falls in decile 7, so you would get 7 points. So to recap, there are 3 different ways that you could report this measure, and of course you're going to report all 6 measures using the same methodology. I did not say that earlier. So with a score of 61, if you report through claims, 6 points. If you report through your EHR, 9 points. If you report through your registry, 7 points. Obviously, you're getting more points through your EHR, but if it's not cost effective for you to use the EHR reporting methodology, or it's not available through your EHR, and many systems do not have that available, then you probably want to consider investing and submitting through your registry because every point matters. So this will give you 7 out of a possible 10 points. And again, we're working towards 60 points. So that kind of sums up how you will look up what your percentages are today using 90 days or the full year, how you cross-check that using your Decile Report. We've talked about you downloading that Decile Report and then looking up each of the measures you want to track.
Liz, Phoebe here. I have a question I'd like to ask, because maybe a lot of the providers are thinking it. Suppose I have an influenza score that's maybe too low. How do I get my score to go higher?
Well, that's an excellent question, Phoebe. And one of the reasons that we're having this conversation now is that, folks, you've got a full 90 days available to you for reporting. So you have time to bring up these scores. Actually, you've got more than 90 days, right, because we're not even at the end of September. I do want to flash just a minute and tell you that you can get just as high a scores for MIPS using the 90-day period this year than using the 365-day period. It just depends on what yields you the highest points. The higher the points, the more potential you have for a positive and a hefty positive adjustment. So if your influenza score, for example, is too low, then you want to look at what the workflow is to document for the screening and preventive care for influenza. And then you want to work with your providers on the clinical side for utilizing that workflow for improving this score. Now, someone may have gotten a flu shot from another provider, but you can still ask them and record that within your EHR, and it would impact the tracking for this particular measure. So if you want your scores to go up, and we would recommend that everybody work on getting their scores as high as possible. I haven't had anybody have a 60 yet, but I just this morning spoke with a 58, so that's pretty impressive. And she's still working on getting those scores higher. Now, if you don't know what the workflow is, and oftentimes we're finding folks don't know how this is tracking. They don't know how they're impacting this particular quality measure. Please go to your EHR vendor and ask them specifically, how do you improve this measure? What are the steps? What coding is necessary? What does it take? So that is specific to your EHR, and you need to go back to your vendor and ask that question. Thank you very much, Phoebe. Okay, I know that was a lot of information, and you can access these slides and go through this, but folks, or if you need us to go through it with you individually, we can, but I will tell you that by the second time we go through with this, you'll think it was easy as pie. So it looks much worse than it is, and once you've used it, it makes sense. Now, we don't have a great deal of time left, and I need to go over these improvement activities with you. Improvement activities is a new performance category for 2017, and the concept is that clinicians would be rewarded for care focused on care coordination, beneficiary engagement, and patient safety. There are 92 measures available, and this comprises 15% of your total MIPS score. Now, again, you'll see the screen as I showed you earlier from the QPP site, and that's because when you go to the QPP site, and you look at the MIPS tab, in that drop-down, you can go to Improvement Activities, and you can look at all 92 of those activities and see which of those activities best suits your practice. And that brings up the question of what is best. Now, I have to admit to you that this year, I'm recommending that most folks do what's the easiest improvement activities. I do want to say that most improvement activities you have to do for 90 days. The easiest, in my opinion, improvement activity is to register for the prescription drug monitoring program, which is required in Georgia for everyone to get done by January anyway. But then I'll turn around and tell you that you have to participate for 6 months to use that as an improvement activity. So if you were already participating by July 1st, that is one heck of an activity to do, and easy to document, easy to prove, and it's a good service and free in the state of Georgia. So, groups of 15 or more must attest that you've completed up to 4 improvement activities for a minimum of 90 days, unless specified otherwise that it requires more than 90 days. Groups with fewer than 15 participants, or if you're in a rural or health professional shortage area, you can attest that you've completed up to 2 activities for a minimum of 90 days. And I want to point out that although we do not have access to the attestation site yet, and don't anticipate having that access until the first of the year when we can begin attesting, this is a yes-no attestation. You pick the measure or 2 or 4, the improvement activity that you're going to attest to, and you check yes. And that seems very simple. But we want to make sure before you check yes that you have the material, the documentation available before you attest. So if there's an audit in 3 years, you've got that documentation available. Because just because you check yes doesn't mean there wasn't something you were supposed to do and maintain for proof. So, participants in certified patient-centered medical homes, which is comparable to specialty and which also applies to specialty practices, or if you're an APM designated as a medical home model, you will automatically earn full credit for this component, 15 points automatically. If you participate in certain APMs under the APM scoring standard, then you will typically find that you will get some credit for this. And again, we recommend that you work with your APM organization to determine what you need to do. Typically, you will automatically be scored based on the requirements of participating in the APM. In other words, the APM has improvement activities associated with it, so you automatically get credit for that. For current APMs, the assigned score will be full credit. For future APMs, the assigned score will be at least half credit. So that may change going forward. Participants in any other APM, other than those, the standard ones, and there is availability on the QPP site to let you know what how your APM qualifies, you'll automatically earn half credit and may report additional activities to increase your score. So this does not apply to most of you on the phone. If you are an APM environment, then that's a conversation you might want assistance with offline with one of our representatives. So let's remember those flexible data requirements for small practices, especially those in rural locations and in health professional shortage areas. You are only required to report 2 activities. And those activities, so let me rephrase that. You're only required to report 2 activities in the improvement activity performance category instead of the 4 that are required for larger practices. Now, it may be that you only have to report 1 activity because improvement activities have 2 different weights. They have medium weighted, which is worth 20 points, and they have high weighted, which is worth 40 points. As you may surmise, high weighted activities are a little more difficult than medium weight activities, but still not that hard to do. So if you pick a high-weighted activity, then you only have to do one. If you pick 2 medium-weighted activities, then of course you have to do the 2. Could you do 1 medium weight and 1 high-weighted? Well, you certainly could, but you're still only going to get credit for 40 points to equal a MIPS improvement activity score of 15. So I would recommend that if you want to do multiple activities and you want to do several 20-pointers or a 20 or 2 and a 40, you might want to save that output or that documentation, that activity for next year. Now, I talked about the site where you go look at improvement activities. You can filter by subcategories, which would be patient engagement or maybe care coordination, or you can sort by activity weighting. You could say, hey, give me all the ones that are 40 points. Let me see if any of those are going to work for me. Again, here's the link to that site, and this is just good information. I know that I've helped many people pick out their 2 activities for this year, but I still recommend, go ahead and go look at what the others are. See if there's something that applies to your practice, because let's go ahead and get ready to do that for next year. Now, there is documentation that is required for most activities. This information can be obtained by going to your QPP resource library, scrolling down to a document called MIPS Data Validation Criteria, and downloading that document or that file, that zipped file. Once you have done that, then you would unzip the file and access, I like to use the spreadsheet version. And what you want to do is you want to check what documents are required for each measure, and you want to check what the timeline is for each measure. Ensure that it's not something that requires more than 90 days if you've only got 90 days left to do the measure. So this document is just as busy or almost as busy as that Decile report. Very similar, as a matter of fact, in the way it looks, but it really has some good information. And you would look up the number based on this activity ID on the left side, which is provided when you find the activity on the QPP site, right here. When you click on that on a specific measure, it will give you the ID, and then you can go to this downloaded report, search for that ID or do a find for that ID, find out what the activity description is, and see what documentation is required. For this particular one, you'll see that this requires the patient records, and there's a 1 and a 2 and a 3 part to this that are ORs. ORs mean you have to do at least one of those. If you want to do all 3, no problem, but you have to do at least one. Now, you must document your process. You want to utilize a project plan or some change management methodology. Maybe some of your organizations have implemented Lean or Six Sigma or some other type of change management methodology. Most that I work with have not, and so we've used the simplest tool available that's most effective. Then you want to maintain that required documentation as listed on that prior document, that MIPS data validation criteria document. You want to make sure you can generate that documentation, and then you want to save it for 7 years. Now, I think technically you have to save it for 6 years and 3 months, but let's just go with 7 years. And if you're saving soft copies, please make sure you've got it backed up in the cloud or on a different system. I sure do have a lot of folks that have system crashes, and then you don't have the documentation. And then we're going to give you a quick example of an improvement activity. One of the ones that most of my practices are using is the improvement activity around beneficiary engagement, which is a patient survey. So this documentation or suggested documentation shows that you want to make sure you have your survey results and that you can show that you're doing regular assessments of the patient care experience to improve the experience. So, first of all, you got to have a survey. So many of you, especially if your members or you participate in one of our hospital systems, many of those hospital systems are doing the surveys for you. So you could then use those surveys as long as you have access to the results, and we can analyze them and determine if there's any places that we need to implement future improvements. And you also want to make sure that they're doing it more than just one time. If you don't have a survey available, we certainly have a simple one that we've created that we'd be glad to share with you. It is a one-page document. We don't require that a patient put their name on that document. And this has, we've had a lot of great feedback from our practices that are using surveys because they're finding things they never knew before. So you've got to have a survey if this is the improvement activity you pick. You can have, it does say up there you could have advisory council meetings with patients on your advisory board or some other method. Quite frankly, the survey is the easiest one we found for this particular method. Matter of fact, this is the next easiest improvement activity that we found. In addition to that survey, you want to have an improvement activity plan. And the easiest one that we've found is a PDSA. That's an acronym that stands for Plan, Do, Study, Act. And it means that you make a plan, and we'd be glad to provide you with a sample plan. And actually, there's one right here on the screen. Not quite finished, but it does give you a little bit of an idea of what you want to do for your survey. It tells you what action items are needed. You'd want to put in the, who's responsible, when you're going to do it, and these are typically done within the practice unless you're mailing them out or unless the healthcare system is mailing those out. Or you have them do them through the portal. And then we have some metrics that we come up with that we'd like to look at on the survey. Basically, we want to see where do we have high scores, where do we think we'll have high scores, where do we think we'll have low scores, and where do we actually have low scores. Again, this is available to you, and we'd be glad to go over this with you and give you some support on using this particular method and to share the PDSA template, because the PDSA template can be used for just about any of your improvement activities. It gives you a guide, and it gives you documentation of proof that you gave some thought to this, you had a plan, you executed on the plan, and knew what the results were. So again, we'd be glad to provide this to you. And then you want to analyze your results. You want to tally your results, and you want to see where were things great, and what did they like about the practice? Where were there any problems? Where did they disagree or strongly disagree? Because if you have folks that strongly disagree with some of these statements, that's probably a place you need to do some improvement on. So after you analyze your results, you want to determine what actions need to be taken. You need to put together a PDSA or some type of plan for it. And then you want to execute that plan, and then you want to do a survey again to see if it impacted the results on your survey. Now, I know that I may have made this more complicated than it is. Basically, you want to do for this particular activity, you want to do a survey, you want to tally your results, you want to have a plan, and you want to look at your results and see if there's any improvements you need to make. And I have to say, folks, this has been extremely successful. And we want you to get at least 2 sets of surveys in before the end of the year. So if this is something you want to do, then we sure would like for you to get started on it next week if you haven't already done so. So, as usual, I've talked too much and didn't give y'all too much time for asking questions. So how about if we look at some questions? Phoebe, perhaps you can share with me some questions that came in and see if we can give some answers to some of these.
How do I look up my claims-based percentages?
So you look up your claims-based percentages where you are today by looking at either your MIPS report in your EHR for your quality component. If you don't have a MIPS report yet, you would run your meaningful use report for current date range. and you would look at the clinical quality measures associated with meaningful use. And if you can't find either of those, and you should be able to get at least your meaningful use report, then ask your vendor or go and look for your QRDA report. Again, that's a much larger report. It gives you much more data than you need initially. But any of those three methods would give you your percentages for specific measures today.
All righty. Very good question. Here's one. How do you handle providers that work in an RHC but file Part B claims for hospital admissions? Can we use data from the RHC setting to meet reporting requirements?
Now, that is a good question, and there are specific requirements for RHCs. That would depend on whether your provider is deemed eligible, or often when we look up RHC providers, they're listed as not eligible for the MIPS program. So that may be something you want to contact us for and let us help you look that up and see where they fall, and then look at the requirements for an RHC. If you're using the typical methodology for submitting claims through the RHC, then you probably don't have to participate. So we want you to take a look at those requirements that are available on the QPP site and look at your specific example to see if they have to participate, and if they do, what we need to do about that.
Okay, great. And we're going to squeeze in one last question. How do you know if you should submit as a group or an individual?
Now, that is a good question, and you're not going to really like my answer, because what you would want to do is you'd want to look at your group scores, the aggregated scores, and look at your aggregated percentages and see what scores those equal, and then you'd want to look at your individual scores and if you percentages and those scores, and see which one gives you the best score. So that's a lot of work, and I understand it. But you may find that you've got one provider who has very low percentages, and if you aggregate that provider's numbers with everyone else's, it would pull their score or their percentage up to a higher score. So typically what we see when folks use group is that they just used group for reporting in the past and they like it, or they have one provider that they need to pull up the numbers for in order to improve those percentages, thus improving those scores. So it's a bit of a hassle, but get that spreadsheet ready and just take a look at how some of your systems will give you both the group and the individual scores, and that makes it a lot easier to look at. If not, you're going to have to put it in a spreadsheet and just make a determination, almost like doing an investment analysis. So look at both ways. If everybody's got great percentages and everybody's got great scores, whatever feels good to you.
Okay.
As long as you're not a very large practice, that kind of goes in a different direction.
All right. Thank you so very much, Liz, and our apologies. We didn't get to all of the questions, but we will try to respond to as many as possible because we have your email in the registration. Thank you so much for joining us for our webinar. Wonderful.
And I would like to say that they've got our email addresses if they want some specific, more customized assistance with their practice. Email us and let us know.
Fabulous. Thank you so very much. Have a great afternoon, everyone.